session, I've been asked to talk about developmental consequences of commissural anomalies. And as I mentioned earlier, I work both in the prenatal and postnatal space as a paediatric neurologist, but I work quite closely with a neuropsychology research group who have an interest in the corpus callosum. So what is the corpus callosum? I've obviously heard a bit about this. It's the main connection between the two cerebral hemispheres, made up of about 200 million axons, but important to remember that there are other smaller interhemispheric connections, the three commissures. Now, why do we need a corpus callosum? Well, obviously we need it for brain processes that require interhemispheric coordination. And some of those processes are higher cognitive functions, complex information processing, coordination of motor function, and importantly, regulation of social and emotional responses. I really like this image from this paper that came out in 2011, which shows the heterogeneity. This was actually in consanguineous families with callosum abnormalities, normal, various degrees of hypoplasia, dysplasia, hypoplasia with dysplasia, and I really like this picture here of complete agenesis with absolutely nothing in the box. So how can you classify these disorders of callosal developments, or DCDs? There are different ways people have tried, either by anatomy. Agenesis can be partial or complete. Hypogenesis, meaning thin corpus callosum, partial or complete. Just a funny looking corpus callosum, dysgenesis, or mixed pictures. You can also classify it as isolated versus complex. And complex means there's associated malformations either in the brain or elsewhere in the body. And probably the best way to try and classify is really once you know the genetic causes. And there are many genes and pathways associated with DCDs, midline patterning genes, primary callosal development genes, axonal guidance genes, cortical development genes. There are also acquired causes, vascular infective toxins, metabolic I've put in brackets because many of those are genetic, but they tend to cause an acquired abnormality by toxic effects on the developing corpus callosum. It's also to remember that these disorders are not the same as split brain syndrome. All the neuropsychology literature about split brain syndrome is in patients who've had callosotomies. So that's completely different. We're dealing here with, in DCDs, where this is a developmental disorder. This is the only brain these patients have ever known. Now, a bit more about genetics. Over 500 single gene disorders associated with DCDs, and depending on which papers you look at, you can identify a genetic cause in about 35% of patients, in postnatal studies with chromosomal abnormalities in about 10%, and intragenic abnormalities detected by whole genome or whole exome sequencing in about 25%. And the diagnostic rates to find a genetic cause are higher when you've got complex ACC as opposed to isolated. This is just a list of some syndromes. I'm not going to go through all of these. We've heard about ARID1B, which is one of the most common, but there are many genetic syndromes associated with different abnormalities of the corpus callosum. And you've heard Aicardi syndrome mentioned a few times. And it's important to know there is still no gene known for Aicardi. So to rule out Aicardi, which we heard about in the previous talk, you really need to do that postnatally. You cannot do that reliably always prenatally, because we do not have a gene yet for Aicardi syndrome. Prognostic factors, etiology, number one. If you can make a genetic diagnosis, you can usually predict the prognosis and decide whether the child's in a good or an unfavourable prognostic group. Associated malformations, and for that you'll really need MRI, and you may not need to look further in the body for other abnormalities. The prognosis is worse with associated malformations. Complete or partial ACC. Well, partial is generally worse prognosis, and that's because partial is usually associated with a higher rate of additional abnormalities or an underlying genetic diagnosis. It's not that the partial ACC on its own is worse than complete in the isolated form, but you're more likely to have associated abnormalities with partial. And it's important to remember epilepsy as a prognostic factor. So, for example, if you have Aicardi syndrome, then you will have abnormalities of the cortex, such as polymicrogyria and grey matter heterotopia. And that's going to dramatically increase your risk of seizures, which leads to this entity that, those of you who are not neurologists might not be familiar with this, a developmental and epileptic encephalopathy in the infant, where they have development abnormalities from the malformation, but they have additional developmental abnormalities from bad epilepsy. Now, isolated ACC, is it really benign? An isolated ACC is a heterogeneous spectrum has a heterogeneous spectrum of outcomes. Again, the most important prognostic variable is the etiology. And the studies in the literature are really quite variable. Older studies and meta-analyses of these older studies suggested a favourable outcome in about 75% of patients. But very few of these studies followed patients into adulthood, and even less of them performed detailed neuropsychological testing. Does favourable mean normal or typical? Not always. So more detailed studies with longer follow-ups and good neuropsychology testing have actually shown high rates of mild to moderate learning problems, sleep disturbances, behavioural and social difficulties, even though in the majority of patients the IQ is normal and the developmental milestones are normal. What about agenesis of the corpus callosum and autism? So I don't know how many of you recognise what's on the right of my slide there. So the top image is Dustin Hoffman and Tom Cruise from the film Rain Man, and Dustin Hoffman is playing a man with autism, and he modelled his behaviour for that role on this man down here who's called Kim Peek, who's a man who had, he's deceased now, a complete agenesis of the corpus callosum, and he was an autistic savant, so very disabled in terms of his social skills and his interactions, but he memorised thousands of books and could read a number of books in a day and memorise each word in them. So there is a strong link between ACC and autism, and in longitudinal studies with good testing into adulthood, it is found that the majority of individuals with complete ACC, and that's isolated ACC, plus complex ACC, have social and emotional difficulties when you followed them into adulthood. And so autistic symptoms or a formal diagnosis of autism spectrum disorder has been found in up to 50% of adults with isolated complete ACC. And this often causes limitations in employment and relationships, such that when people have followed these individuals into adulthood, it's been found that they have a significant number have had problems forming relationships, getting married, and holding down employment, or fairly restricted in the types of employment they can do. And these are a number of the milder sequelae where these symptoms are more common in patients with isolated ACC compared to the general population. They're not always severe disabilities, but you can have borderline or mild ID, academic difficulties, ADHD, impaired attention, language difficulties, impaired processing speed, visual perceptual disorders, motor coordination disorders, impaired executive function, social and interpersonal difficulties. And there's quite a deal of literature out there. This is from Vanessa Safredi, who was in our group for a number of years and now is back in Geneva. But some of the most important papers have come out of Caltech. Warren Brown and Lynn Paul, who are both neuropsychologists, who have followed patients from early childhood all the way through adulthood for many decades, and have nutted out some of these milder sequelae. So unfortunately, the 75% of people who have a favourable outcome, if you follow them closely enough and for long enough, you realise you really do need a corpus callosum. Okay, let's move on and to tell you the importance of genes. 3 cases, 3 outcomes, 3 causes. These are all patients of mine. This was a boy referred to our clinic. He had a head injury. He was otherwise a healthy, well boy, normal IQ, normal development, but his imaging showed no corpus callosum. A microarray and a trio exome were normal. I've not continued to follow him into adulthood, so I'm not sure how he's doing now. This is another patient that was part of a study of ours where we published the identification of the gene DCC in patients with agenesis. This is a boy from a family where his two brothers and his mother were all affected. They all had very similar problems of ADHD, a mild learning disability, and mirror movements, and a pathogenic variant in DCC. And DCC actually does not mean disordered corpus callosum. It actually, the gene is called the deleted in colorectal cancer gene. And that's another story for another day as to why the gene is called that. And this was another patient of mine from an autosomal, from a consanguineous family. Him and two of his siblings had profound global delay, acquired microcephaly, limb spasticity, death at the age of 2, and these individuals had a pathogenic variant in AMPD2. So 3 images that look pretty similar with vastly different outcomes. And the genes, obviously we didn't find a gene in this boy, which puts him in a better prognostic group, but the genetics here helps with the prognostication. Now, what about the prognosis in partial ACC and other complex types of disorders of cortical development? And this is quite tricky. The most important prognostic factors are still the etiology and the associated malformations. The existing literature for partial ACC and complex DCD shows a worse outcome than for isolated complete ACC. So-called typical outcomes, and that doesn't mean normal, and I know that sounds funny, but neurotypical can have a wide spectrum, and normal means different things to different people, but most parents will ask you not, is my child going to be typical, but is my child going to be normal? Typical outcomes are reported in about 70% of patients, which is similar to isolated ACC. Now, that's for isolated partial agenesis, but goes down to about 40% in complex partial agenesis, but still the literature is not perfect for those patients. Management of the comorbidities such as epilepsy, visual impairment, hearing impairment, assistance with learning will improve the prognosis. How do I counsel? So this is my personal opinion, and as I said, I mainly do postnatal work, so perhaps my approach and what I see is a little bit different to the fetal setting, but I also do some fetal work. It's difficult. Before meeting the couple, I'll review the fetal MRI and the report. I may go back and discuss the MRI with the reporting radiologist. I'm very interested to know what investigations have been done in the pregnancy, especially testing for infections and genetic testing, take a family history, and I may examine the patients for mirror movements. And I mentioned mirror movements before in the context of tubulonopathies, but they're also relevant for abnormalities of the corpus callosum. And for those of you who don't know what mirror movements are, it's when you purposefully move one side of the body and involuntarily move the other side of the body, usually to a lesser extent, and you cannot suppress it. So this is a patient of mine referred to me. She doesn't have agenesis of the corpus callosum, but let's pretend she has, because this occurs in some patients with agenesis. The medical name for mirror movements is bimanual synkinesis, and here I'm telling her to move her right hand, and her left hand's moving involuntarily. And here I'm telling her to move her left hand, and her right hand's moving involuntarily. Okay, I'll just show that again. And you can do this in the clinic, where I tell them to put their hands out and quack like a duck, and I deliberately say only move one hand, don't move the other one, and then switch. And the faster they move, the more it brings out this abnormality. And for the clinicians out there, this sort of thing can occur as a normal movement in very young children, maybe up about to the age of 5, but this mirror movement should not persist beyond that age. And there she goes again. And I'll just stop that. And there's also something called sensory mirroring, which we don't routinely test for in the clinic and is much rarer, where you can sort of, say, tickle them on one side of the cheek and they will feel that on the other side of the cheek at the same time, which also can occur in axon guidance problems, including callosal abnormalities. So now we move on to how do I counsel for isolated ACC. So if there's no red flags such as additional abnormalities on the MRI or abnormal genetic testing or a strong family history of neurodevelopmental disorders, I do tell parents there's a 75% chance of a favourable outcome, but I explain that a favourable outcome means normal developmental milestones and intelligence within the normal range. But I do counsel that learning problems, social and behavioural issues, including autistic symptoms, are more common in the general population, but may not be evident until later childhood or adulthood. And these children do need closer developmental, behavioural and emotional surveillance, and particularly in the early part of their life, but some might say to be aware of these symptoms throughout their life. What about counselling for isolated partial ACC with no red flags? Similar counselling as for isolated complete ACC, so favourable outcome with the usual caveats. For isolated hypogenesis or dysgenesis, I really think it's impossible to provide accurate prognostic advice in the absence of a genetic or a syndromic diagnosis. And there is nothing wrong with saying, I don't know, time will tell. If you really don't know, then to try and make something up. And parental tolerance for the unknown will vary greatly. Some will go ahead if this is in the fetal setting and just wait and see what happens. And for others, even a small degree of an adverse developmental outcome will be something they won't be able to tolerate and will request a termination of pregnancy. If you have a genetic or syndromic diagnosis, you can counsel accordingly, and that usually will require referral to a clinical geneticist. And if you have a brain malformation, you can usually counsel accordingly for that as well, including the high risk of epilepsy, cerebral palsy, or intellectual disability. And we always advise parents how to recognise seizures in infancy. Because of what I mentioned before, developmental and epileptic encephalopathies, you do not want a child to have an additional developmental disability because you've been late to recognise their epilepsy and treat it. What follow-up do these children need postnatally? They need assessment by a paediatrician after delivery. They need ongoing paediatric review during the first 2 years of life minimum, and consider referral to a paediatric neurologist early as well to examine the child, discuss the pros and cons of a postnatal MRI, consider further testing for etiology, referral to a clinical geneticist, especially if they're planning further children, and advise the parents to watch for red flags such as developmental delay or seizures. So this is my last slide. So we have a lot of marsupials in Australia, so they're non-placental animals. Most of them are very cute, and this is one of them called the fat-tailed dunnet, and marsupials do not have a corpus callosum. None of them do. That includes kangaroos, koalas, and the fat-tailed dunnet is the mascot of our local Australian Disorders of the Corpus Callosum family support group. So that is my last slide, and I'll leave it at that.
Thank you very much, Rick, for this nice overview, and especially for your suggestions how to handle these patients after birth. So this is the end of this